Good morning, everyone. Good morning, ladies and gentlemen. Thank you for spending your Saturday morning with us. My name is Emil Tan. I'm Head and Senior Consultant of the Department of Colorectal Surgery at Singapore General Hospital, as well as the National Cancer Centre, Singapore. Welcome to the annual Colorectal Cancer Awareness Public Webinar. This year is a very special one for us as the Department of Colorectal Surgery at SGH celebrates its 35th anniversary, a significant milestone for colorectal surgery in Singapore. Our journey, however, is far from over, and we are committed to serve you, our patients, and ensuring that every individual receives the care and support they need to live healthy and fulfilling lives. Colorectal cancer is the #1 killer in Singapore. Nevertheless, 95% of it is treatable when treated early. As such, awareness and early screening is extremely important. Detection is simple, and screening tests are readily available and easily accessible across Singapore. Early screening leads to prevention, and early detection leads to cure. Through today's webinar, we hope to create more awareness on colorectal cancer. Without further delay, may I introduce our first speaker, Dr. Lionel Chen, a consultant surgeon of the colorectal department. He will present on the topic, Is colorectal cancer that common in our population? Any early signs? Dr. Lionel, please.
Thank you, Professor Emil, for the kind introduction. I am Dr. Lionel, one of the consultants from the Department of Colorectal Surgery, Singapore General Hospital. And today I'll be presenting on whether colorectal cancer is common in our population, any early signs. So, what is colorectal cancer? So colorectal cancer is the cancer of the large intestine or the rectum. And most of the time, it takes some time for it to develop over a few years. It usually begins as a small polyp, which is an abnormal growth of tissue in the inner lining of the colon and rectum. And you can see in this diagram that as it grows over time, it gets bigger and bigger, and it ulcerates through the inner lining of the muscle wall of the colon or the rectum and becomes cancer. How common is it in the world? It's actually the third most common cancer worldwide. It makes up about 10% of all new cancers in the year of 2020. And we can see in the rightmost pie chart that close to about 9.4% of all cancer deaths in the year 2020. Globally, there are about 2 million new cases diagnosed annually. But how about in Singapore? It is the second most common cancer amongst men and women based on the Singapore Cancer Registry report published last year in August 2023, based on data from the 2021 report. And we can see here that from 2017 to 2021, over a span of 5 years, about 12,239 new cases were diagnosed. What this means is that every day, 6 to 7 new cases of colorectal cancer is being diagnosed in our country. In terms of mortality from colorectal cancer, about 4,415 patients have died over a span of 5 years. What this means is that there are 2 to 3 cancer deaths from colorectal cancer every day. So what are the symptoms of colorectal cancer? They sometimes present with change in bowel habits, such as a change in your stool pattern. For example, if you have been passing normal stools every day, suddenly you notice that you have increasing constipation, difficulty in emptying your bowels, and incomplete emptying that is lasting more than 2 weeks. That may present and suggest that there are changes in your bowel habits. Sometimes you notice when you pass motion that there's blood in your stool, or sometimes these tumors, such as rectal tumors, can bleed. Or if you notice that you have losing significant weight loss over the past months to about 1 year, about 5 to 10 kg. Or sometimes if you notice that you feel more bloated in your abdomen, you increasing abdominal cramps and discomfort, and this is lasting about more than about 2 to 3 weeks. All these are possible symptoms of colorectal cancer, and it may require you to visit your doctor for a checkup or investigation. But are there any early signs for colorectal cancer? Unfortunately, there are no early signs for colorectal cancer, and those 4 symptoms and that I have described actually present when they are later stages of the cancer, whereby they have grown in certain size, so much so that they bleed or cause obstruction or blockage and result in these symptoms. Therefore, we suggest that you should not wait for these signs, in fact, or symptoms to develop. In fact, take control of your health. And how can we take control of health? By first, maybe adjusting some modifiable risk factors, ensuring a healthy weight, going for exercises, and controlling your diet, or maybe cutting down on things that may predispose you to cancer, such as smoking and drinking of wine or alcohol. But the most important way to prevent colorectal cancer is to actually go for colorectal cancer screening. Because even if you lead a healthy lifestyle, sometimes you may still have a risk of colorectal cancer. And to go for colorectal cancer screening, there are a few ways, such as screening for your stools, going for a CT scan to check the colon, or for example, going for a colonoscope. In our country, if you are asymptomatic and of average risk, we advise that you should go for screening if you are 50 years and above. And if you are high risk, for example, you have a family history of colorectal cancer in your family, or history of any inflammatory bowel disease, or any hereditary syndromes, such as familial adenomatous polyposis or HNPCC, there is advice for you to consult your doctor early to go for a earlier colorectal cancer screening. I'll next pass the time on to Dr. Isaac Siao, who will be talking about further detail as to how we perform colorectal cancer screening in our country. Thank you.
Yes, thank you, Dr. Chen. My name is Isaac Siao. I'm a consultant with colorectal surgery. And today, my talk it will be on how do I get screened for colorectal cancer and how it saves lives. Okay. Sorry, one moment. Okay, can you see my screen?
Yes.
Okay, so colon cancer, as Dr. Lionel has shared, is abnormal growth in the colon. Here you can see the pictures of the tumor, and this arises from a polyp. And you can see that the colon and rectum is divided into different parts. And cancer can develop in any part of this large intestine. Now, as Lionel shared, in Singapore, colon cancer is the most common cancer in males and the second most common cancer in females. But overall, it is definitely the most common cancer amongst the Singaporean population. And here you can see the incidence of colon cancer a bit in the 60s, 70s, 80s to 90s, and the 2010s to 2017. You can see the incidence is rising amongst the elderly population more recently. This could be due to certain risk factors or the increase in screening that we have promoted recently in Singapore. There are some statistics. You can see amongst males and female patients, Chinese people are more predisposed to developing colorectal cancer compared to Malays or Indians. This is the same amongst males and females in Singapore. And here you can see that again, amongst the population, male patients are more likely to develop colorectal cancer compared to female patients. And the risk of developing cancer increases sharply from 40 to 50 onwards. So the blue line represents the males and the red line represents the females. Now, this is a very important slide. And you can see that amongst the patients with colon cancer, cancer is divided into early stage 1 and 2 and later stage 3 and 4. And amongst those diagnosed, 1/3 of patients are actually already in stage 3. And 1/4 of patients, or 1 in 4 patients, are already stage 4, which means they have spread to other organs. And overall, about 60% of patients are diagnosed at, at the first instance, having stage 3 or 4 cancers. Now, why is this the case? And as Lionel pointed out, this is because that early colon cancer has no symptoms. And this can be for many, many years until the tumor is large enough to cause symptoms like bleeding or change in bowel habits. Of patients that we see with colon cancer, about 10 to 20% of patients have a family history, meaning their parents, relatives, uncles, aunties with colon cancer. But the vast majority actually have no family history of colon cancer. Now, who is at risk of developing colorectal cancer? Now, everyone, all right, because it's so common, and polyps are very common as well in the population. But there's a certain group of patients which are higher risk than average. And these are patients with a family history of cancer, as mentioned, parents, uncle, aunties, siblings, or those with a family history of polyps as well. Certain special conditions like familial adenomatous polyposis or FAP, or patients with non-polyposis colon cancer syndromes. Now here you have a picture. This is a very dramatic picture of a colon that is full of polyps. Now this is quite a rare condition, but one we see in SGH quite fairly often, where the colon tends to develop polyps and the risk of cancer is 100% in these patients. Additionally, patients with inflammatory bowel disease also have a higher risk of developing colorectal cancer. Now, how does screening prevent colorectal cancer? As mentioned before, 1/4 of patients in the general population above 50 years old have polyps. Now, this is a staggering number. And the risk of development of polyps increases with age. And screening is meant to pick out these polyps when they are small and benign before they become cancer. And most polyps can be removed on colonoscopy before they have a chance to develop into bigger polyps and to cancer. Here you can see the progression of a small tumor and stage 1 cancer, stage 2 cancer, stage 3 cancer, and stage 4 cancer, where it's already spread to other organs. Now, patients with small polyps like this, or even small tumors, do not have symptoms. This is important to stress. And once symptoms have developed, it's usually stage 3 or stage 4. And clearly the chance of success of treatment is higher when the polyps are detected early or the cancer is detected early. And screening has been found to prevent 60% of colorectal cancer deaths. How? 1, by removal of polyps before they have a chance to become cancer, or detecting very early cancer where treatment is much more successful. Who should be screened? Now, for patients who have no symptoms, the average age of patients, screening should start at 50 years old onwards. And screening before 50 years old can be done in patients with a family history of polyps or colon cancer, or patients who have symptoms. These things, as mentioned by Lionel, with blood in the stools, change in the bowel habits, loss of weight, etc. Now, these are some screening options. The first, I think most of you are aware of this, is the fecal immunohistochemical test, or FIT. This can be done yearly, or the colonoscopy. This, for the average risk population, is done once every 5-10 years, but in certain patients, this can be done earlier. Now, these are the two most common types of screening tools, and the rest, we'll talk about it later, but it's quite not so often recommended by specialists. Now, we go into the fecal test, or FIT. Now, the purpose of this test is to detect very, very small amounts of blood in the stool, which are not seen by the naked eye. Because if you can see blood, that means you're symptomatic, which means that you already should be seen by a specialist, right? Or at least a general practitioner first. But this to pick up microscopic blood, which cannot be seen. Now, why is it important? Because polyps or tumors can cause a small amount of bleeding to be shed in the colon. And this is passed out in the stool and can be detected using this test. However, it's important to stress that many conditions, not just polyps and not just cancer, can also result in some blood in the stool. That is why it's very important after this test is detected to be positive, to be seen by a specialist to decide whether or not you should go for colonoscopy. Now, this is how it's done. There's a small kit where you can twist off to dip in the stool and send it off for testing. The colonoscopy, I won't talk about this too much because my next speaker will be talking about it. But essentially, it is a long tube about the finger thickness, and this is put into the anus, into the start part of the colon. And this has a camera at the tip with a light source and allows the doctor to see the entire colon and rectum. Now, these are some pictures of colonoscopy. Here you can see a normal area of the bowel. Here a small polyp, and this is a larger polyp which is removed, and this is cancer with a very small narrow lumen in the middle. Now, how do we remove polyps on colonoscopy? The first way, if the polyp is a bit bigger, we can snare it using a special device to bite it off at the base. If it's quite small, we use a small a biopsy forceps to remove it. And both ways are good for removal of polyps. And removal of the polyps prevent them from becoming cancer. Now, there are many types of polyps, right? Here we have some types or medical terms, but adenomatous polyps are the ones with a risk of becoming cancer in the future, even though there are many types of polyps. And adenomatous polyps, they either have a higher risk or lower risk of becoming cancer. And some features predispose them with a higher risk of becoming cancer. These are polyps more than 1 centimeters, more than 3 polyps, what we call high-grade changes or high-grade dysplasia. This means they are almost about to become cancer. And here we see a very large polyp. This is still not cancer yet, but it's a high-grade dysplasia that can become cancer shortly. Sometimes we even use surgical methods, not just colonoscopy, to remove polyps that are very low down, close to the rectum and the anus. And here you can see the type of surgery we do. Removal of the polyp very close to the anus. This is done through the anus itself, this type of surgery. Usually, if we see a cancer, we need to remove some cells first to determine whether or not the cells are cancerous. And these may take about a week or 2 to confirm. So here we have a comparison of a fecal test and colonoscopy. Now, the fecal test is usually done once a year. It's very convenient. You can do it at your own home, right? After passing motion in a toilet bowl, and it's self-administered. It's not invasive. There's nothing up the bottom. But if positive, usually we require colonoscopy. And there is a chance of false positives because there are many other types of conditions that can cause blood in the stool, not just polyps or cancer. Now, colonoscopy is done every 5 to 10 years, not every year like a FIT. However, it's the gold standard for evaluation, meaning that it's the best way of looking at the bowel wall and determining whether you have polyps or cancer. At the same time, polyps can be removed during colonoscopy, unlike the stool test. However, it is an invasive procedure with some risks involved, although they are low. So in summary, for patients with symptoms like bleeding, change in bowel habits, go for colonoscopy. If there are no symptoms and no family history and no special conditions, you can do either a FIT or a colonoscopy. Now, some other less common methods of looking at the colon would be the CT scan. This is a special CT called a CT colonography. And this involves pumping of air into the bowel to look at the entire bowel wall from the start to the end. Now, this actually is quite an accurate method of looking at the colon. However, the problem is that there is no chance of removal of polyps during the procedure because there's nothing put in. You can't take anything out either. It's just for diagnosis. So if this test is done and we find polyps or growths, we may have to do a colonoscopy after that. Now, this is another common method, blood markers. The common one for colon cancer is called the CEA, right? Carcinoembryonic antigen. And this is very commonly done in the polyclinics or GP clinics as well. However, it's less useful to look for colorectal cancer than a stool test or a colonoscopy. Why? Because many conditions can cause a raised CEA, right? These are some of the conditions, but this list is not exhaustive. There are many other conditions as well that can cause a raised CEA. And additionally, not all cancer gives a raised CEA. So sometimes you may have small cancers or even large cancers that do not produce this particular marker. So it's important that we all understand that this test may not be so useful as a colonoscopy to diagnose colorectal cancer. However, in certain instances where cancer is already diagnosed and this particular cancer produces this blood test, then we may use this test to look for return of the cancer after treatment. Thank you very much for your time. And I'll pass time over to Dr. Aaron Sia for what it's like getting colonoscopy in SGH.
Okay, hi everyone. Thanks Isaac for such a great presentation. Today I'm presenting about how I like getting a colonoscopy in SGH. I'm Dr. Aaron Sia. I'm one of the associate consultants from the Department of Colorectal Surgery at Singapore General Hospital. Let me get my slides up. Okay, yeah. Let's get started. Okay, let's first get started. What exactly is a colonoscopy? I think as Isaac already previously mentioned, it's a small procedure where you put this fiber optic tube up through the anus. It goes all the way, sees all the different parts of the colon, the large intestines, goes all the way to the right side, where it changes and turns into the small intestines. The benefit of this colonoscopy is by doing so, it lets us see the internal lining of the colon itself. I'm sure Lionel and Isaac has already mentioned the colorectal cancer is one of the leading causes of cancer in Singapore, second in males and first in males and second in females. And colonoscopy, as also Isaac mentioned, is one of the most sensitive ways to diagnose colorectal cancer. So some of the reasons to undergo colonoscopy will first be its diagnostic value. So this can be used in patients who first present with bleeding from their anus or from their rectum. It allows us to look for different causes and to evaluate the cause for this bleeding. So some of the potential causes, as listed on the slides, should be possibly inflammatory bowel disease, could be diverticular disease, which is relatively common in our population. It's a degeneration of the colon with some outpouching. These do present with PR bleeding once in a while. Could just be inflammation of the colon, as seen as colitis in the third picture, or it could be abnormal blood vessels, such as angiodysplasias. So this helps, by doing a colonoscopy, helps us to find out what is the exact cause and how we best manage these the causes after that. Also, as Isaac and Lionel mentioned, the one very good value of colonoscopy is that it allows us for detection of screening for colorectal polyps and also for cancers. Like Isaac mentioned, at the left side, you see small benign looking polyps, which are very early in the stage. If these are not removed or detected early, they slowly progress towards the right side and may eventually become cancer, which is seen on the right nose image here. So fortunately with endoscopy, not only does it allow us detection, it also allows us to do therapeutic procedures. So if on the left, we see someone who does present with cancer, which cannot be fully removed on endoscopy, we will biopsy this lesion, send the cells for testing, and then diagnose and find out exactly what the cause of this lesion is. In the event that the polyps are small, again, we could do a snare polypectomy, which is complete removal of the polyp itself. We'll send this for testing to confirm that it is just a normal polyp, following which then later we can decide whether or not we require an earlier scope at a subsequent date. Some other more rare indications for scopes will actually be possibly removing of foreign bodies. This can be more commonly seen in the children age group or the pediatric population, where they swallow unwanted materials. Other indications would be that of whether in patients who are actually actively bleeding from the colon, we actually may use colonoscopy to stop this bleeding. This can be done through either clipping of the blood vessels, as seen in the middle image on the bottom row, or using a laser coagulation, using laser to burn off these small blood vessels. This is seen in the bottom right-hand slide. Okay, of course, with every procedure, there are some risks involved. So some of the risks of colonoscopy itself will be when we do proceed with colonoscopy, we usually give sedation. Sedation itself do have its risks. Some of it will actually be introduced. The sedation medicines, some people may have actually allergic reactions to these medications. We won't know beforehand, but in the end, if we do give these medications, they'll be monitored very, very closely. Sometimes upon giving sedation, they may also result in there being a low blood pressure and a high heart rates. This may actually induce a small risk, very minimal risk of stroke and heart attacks, but we will monitor very closely during the procedure and during the sedation. In the event there's any resuscitation required, they'll all be readily available. The risk of colonoscopy itself also can be procedure related. Sometimes after colonoscopy, especially after polypectomy, there may be a risk of a persistent bleeding. If this occurs, then we may require another repeat procedure, as previously mentioned, to actually stop the bleeding, either by clipping or burning of the blood vessel. There's also a very, very small chance of less than 1 in 1,000 patients in whom we actually do the scope. It may actually cause a hole in the colon wall. This is called perforation. Very small chance, but if this does actually occur, may actually require to do surgery to close up that hole. But it's less than 1 in 1,000. So if after all this and everyone is still keen to proceed with colonoscopy, how do you actually prepare to go about doing this? First, regarding periscope, we actually do require some preparation. For the long-term medications wise, actually most of them can be continued during the scope period. We would actually like advise to stop anti-diarrheal medicines and iron tablets at least 1 week before the scope date. This is actually to make sure that the preparation of the colon is all clean so that we can properly visualize the colon wall. Some of our patients may actually be on blood thinning medications. This may be required to be stopped temporarily before the procedure. The duration of when to stop these blood thinning medicines actually depends on the type and why these blood thinning medications were given. Usually, we actually would advise everyone to highlight to the proceduralist beforehand what medications they're on so that we can properly advise. Please do not stop these medications on your own before the procedure and follow the healthcare advice that what we're advising. Usually, diabetic medications and blood pressure medications do not really need to be adjusted. You can actually continue them procedurally. Before the scope itself, it's also very important to actually have proper dietary preparation. We usually advise to start this 3 days before the scope. Take low fiber meals and very light meals. We also advise to avoid high fiber food and dairy products at least 3 days before. So fruits and vegetables are actually recommended to be avoided 3 days before the procedure. We also prescribe mechanical bowel prep before the procedure. This actually helps by clearing all the stools out of the colon so you can properly assess the colonic wall. Multiple products are available in the market. The ones more commonly used is usually a PEG, Votrans, the one on the left, and we usually sometimes use PicoPrep, the one on the right. This actually involves diluting these powder sachets into water and then drinking, which will help to purge and clear the whole colon. The timing of which will actually depend based on the timing of your scope, which will be advised if you do come for colonoscopy and the listing. So as you can see on this slide, it actually shows the level of bowel preparation during the colonoscopy itself. On the bottom, when you score 3 excellent, you can actually see the colon wall is actually very, very clear with no stools at all. This actually allows us to properly see the colon wall to properly detect any early polyps if present. On the upper half of the screen, if you do see, if the preparation is not so good, the large stools will actually be coating the lining of the wall, and we will not be able to properly visualize any polyps. In such cases, if it's inadequate visualization and it's insufficient, some of our patients may actually require to go for repeat bowel preparation and a repeat scope to at least get the quality required. So what happens during colonoscopy itself? It's usually a day procedure. The patients will come in early in the morning. Upon registration, we'll do the procedure checklist, make sure it's the right patient, the right indication, following which you get the patient to turn towards the left side, knees bent, and then prescribe a sedation. We need to make them feel comfortable during this procedure. Subsequently, we insert the scope through the anus, and then we start blowing air to open up the anus, the colon, so we can properly see and visualize the wall. We would like to emphasize at this point in time that a majority of the scopes we do actually is not a painful procedure. It's not a painful procedure. Most patients that we have seen and doing follow-up actually do not even remember having undergone the procedure. So that's contrary to popular belief. After completion of the scope, they may experience some mild abdominal discomfort and bloatedness. This is due to blowing up the air and the insufflation. This usually resolves very quickly once the patient awakes and passes off all the gas from the backside. They'll be absorbed in recovery for about 1 to 2 hours, allow the sedation to wear off. We would highly recommend and suggest that there should be no driving or going back to work for at least 12 hours due to the effect of sedation after the procedure. When you do come for this, if a medical certification is required, we can provide such for the day itself. After the colonoscopy is done, the results will be explained either by us, the doctors, or the nurses prior to discharge, and we will give a follow-up if required, if we do find any polyps that require some further testing. Yeah. I think the other alternatives is colonoscopy, as Isaac also himself mentioned. This is a CT colonography. Like he mentioned, this helps early detection of small polyps. But however, if there are such things, we will not be able to remove them on the spot itself. So, but this is less invasive. In the event if we do go for this and there are lesions, patients in the end may still require to do an endoscopy. Yeah, but this is one alternative to doing a colonoscopy itself. Yeah. Okay. So yeah, that's all I have for today. Thank you for your attention, and I hope I managed to clarify any misconceptions. Thank you.
Okay, thank you to all our distinguished speakers. We move now to the question and answer session. I'm going to direct this to our distinguished speakers now, Dr. Lionel.
Hi, thanks for the questions. So the first question is, colonoscopy recommended even if I have pulse? Well, it really depends on a few things. One, if I use having symptoms such as colorectal bleeding, which may be associated with pulse, but sometimes we are never too sure whether even such colorectal bleeding can be due to pulse per se, because as we know, as I mentioned earlier, even colorectal cancer can present with blood in the stool. And therefore, if you are symptomatic and present with symptoms as mentioned in my talk, then I do recommend that you should go for a colonoscope. If you are asymptomatic and you are above age of 50 and your average risk, meaning that there's no risk factors in your family, then you should go for a scope at 50 years and above. Thank you.
Yes, this question is, does eating probiotics help to reduce the risk of colorectal cancer? This is a very interesting question. Someone asked what causes colorectal cancer in the question Q&A box. And as I mentioned, there's no one real cause because it's often multifactorial, where a combination of age, genetics, environmental factors, even the race can increase your risk of developing colon cancer. Probiotics or changing the intestinal bacterial composition or flora has been studied, and in fact we are doing a study right now on SGH, but there is no definite evidence right now that eating off-the-shelf probiotics helps to reduce the risk of colorectal cancer. But this may be something we look at in the future because we're doing studies on it right now.
So yeah, I think I'm answering the question about the pros and cons of CT colonoscopy as compared to colonoscopy. I think this was actually covered by Isaac and covered quite extensively. So again, the CT colonoscopy, usually what we do is we just put a small bubble tubing into the rectum. And then what it does, it just blows gas to cause the whole insufflation of the colon. Once it's insufflated, they'll just do a CT scan, mainly looking for any wall thickening or any polyps in that region. And so the benefit of such a thing is that it's less invasive. The risks are a lot lower as compared to colonoscopy. There's no risk of actually bleeding after that. There's also a smaller risk of actually having perforations or a hole in the colon. The drawbacks of doing a CT colonoscopy is that if we do it, it is purely just for diagnosis. If we do see anything on the scan itself, we are not able to biopsy it to find out exactly what it is, or if any small polyps, we are not able to remove it on block. So that's the other drawback of CT colonography. If we're not able to treat it at that point in time, these patients in the end, when we see clinic again, will eventually still require a whole colonoscopy to actually sort it out. So that's one of the cons of a CT colonography. The cost itself, I think both are Medisave claimable, but I'm not entirely sure about the exact cost. I don't know if my colleagues can actually help me with that. Yeah, I hope that answers the question.
Okay, so the next question is, generally colonoscopes is done every 5 to 10 years, but the 5-year gap is rather wide. Do we do the colonoscopy on the 5th year, in between, or the 10th year? Please advise. This is a very interesting question. By guidelines internationally and in the Western literature, actually, if you have a normal scope, you can wait about 10 years. But sometimes we advise that yes, and why is that? Is that sometimes it takes about that long duration for a polyp to develop from a small polyp again to maybe a cancer. That being said, we recommend sometimes to do it a bit earlier in our country, given the high incidence of colorectal cancer, and especially so that we want to pick up the polyps earlier. But we also have to balance that being performing the procedure as well as the risk of the procedure. Yes, the scope is low risk. Yes, the risk of a perforation or bleeding from a scope is less than 1% in our unit. However, if you were to do a scope every year, you increase your risk for developing complications from the procedure, as well as increase the cost of doing to yourself if you do the procedures too regularly. Therefore, by weighing the risk and benefit ratio, we have sometimes advised our patients to go for a scope between 5 to 10 years after a normal scope. Thank you.
Yes, it's a very important question. Is fecal testing instead of colonoscopy good enough? The answer to this is yes. In the majority of cases, it is good enough, assuming that the patient is average risk. By average risk, meaning there are no symptoms, you're totally well, and you have no family history of cancer or polyps. So in this circumstance, it is good enough, and especially if the test is negative. So if test is positive, then it's not good enough, because test positive, you need to be referred to a specialist to talk about further investigation, including colonoscopy. Hope answers the question. Thank you.
Hi, so answering the next question. So I'm a 66-year-old male. I've had a colonoscopy 3 times with no polyp found. Last one was done in 2019. Can I replace colonoscopy with FIT screening instead? If not, how often is colonoscopy screening required? So I think it's a relatively interesting question. The fact that here you had 3 scopes done before with no polyp found, and the last one was done in 2019. I think as Isaac mentioned, in this case, he's considered an average risk individual. He has actually no known polyps before, no history of any polyps on any scope before. So I think FIT screening would be adequate in his case based on guidelines. If you do yearly FIT screens and they're all persistently negative, there may not really be an indication to do colonoscopy. Of course, if you want ease of mind, the sensitivity for colonoscopy as compared to FIT is significantly higher. And I think the risk is relatively low. So if keen, it still can be done. But yeah, I think actually FIT screening yearly may suffice, and assuming it's all negative with a low threshold, if anything turns positive, to get an early scope. Yeah, I hope this answers the question.
All right. So the next question is, I had rectal cancer at age 51. How old must my kids start to do colonoscopy? So if you are diagnosed with any form of cancer, and for your children, they are considered your first-degree relative. As per what is advised by Western literature, as well as our own national guidelines, that you should advise your kids to start at your scope at about age of 40. So they should go for colorectal cancer screening at the age of 40. However, of course, if there's any form of genetic component, such as any familial adenomyosis, polyposis, or HPCC, then you will be advised for even earlier screening. And if you have, for example, developed cancer at an earlier age of, for example, 40 years, for example, then it's advised that you should let your relatives who are first-degree relatives to have screening to start 10 years before the initial onset of cancer in the family. Meaning that if you are, for example, if you are diagnosed at age 40, then you should advise your kids to maybe go for screening at the age of 30. Thank you.
Okay, the question is, if my mother has cancer at 70 years old, does this mean I have a higher risk due to the genetic disease? Very important question as well. When we say genetic or hereditary colon cancer, it specifically refers to either FAP or Lynch syndrome or some other rarer diseases like this. All right. If your mother has cancer at 70 years old, it's probably less likely that she has one of these diseases. Okay, because this is specifically diagnosed for patients with a very, very much higher risk of developing cancer from specific genetic disease. This means if your one relative, isolated, quite elderly, has cancer, it means that likely your risk is higher, but not as high as patients with an underlying genetic problem. Okay, so usually this is diagnosed by a specialist who have a particular genetic problem. Your risk may be higher, but it's quite unlikely that you have this genetic underlying disease. Thank you.
So the next question is, sometimes feces may be red or have some blood as well, but it goes away after some time. When should we know when it is concerning? I think once you have feces or blood in your stools, actually it should be relatively concerning. We cannot say with absolute certainty that what this may be due to. Most commonly, of course, may just be due to piles, and we may not be, and it's something not too worrisome. But of course, to have safety in mind and to be assured, we actually do feel that it would be better to get reevaluated by one of our colorectal surgeons, so we can properly ascertain what's the cause for this. Of course, if it's young and there's really just piles, nothing to worry about, we should be able to see in clinic, and then we can properly advise on whether or not you should actually go for a colonoscopy. If you're above 50 years old, I think the benefit of a colonoscopy in this case will actually be relatively high if it has not been done before, as it's either way is part of screening. So if you do have symptoms such as a colorectal bleeding and which has not been evaluated, maybe worthwhile actually having a consult with our surgeons. Yeah.
Okay, so the next question is, I recovered from cancer, the next colonoscopy has polyps. Do I need to wait for another 5 years? Polyps may develop within the next 5 years. Well, if you have, firstly, I need to clarify with you what kind of cancer is it really, was it colorectal cancer? And if it is, that means you are at a higher risk of developing another cancer or developing polyps. And therefore, if your screening, if your surveillance scope, that means if you had you were treated for colorectal cancer, and usually we will repeat a surveillance scope for you on the 1st, 3rd, and the 5th year after your treatment for colorectal cancer. And if any of them show any form of polyps, then of course we'll have to repeat the scope earlier, maybe within 2 to 3 years after the last scope. Okay, yeah, thank you.
If my FIT is negative, should I still go for colonoscopy screening that's invasive? Usually no. So your FIT is negative and you are average risk, you have no family history, then there is no need for you to go for colonoscopy. That's the most common answer for this question. Thank you.
Yeah, so I think my question is colonoscopy recommended at once every 5 to 10 years, starting from 50 years old. Yes, so I think based on the Singapore guidelines at this point in time, we do recommend screening colonoscopy once every 5 to 10 years, starting from 50 onwards. The trend for this now actually is we are starting to see an earlier detection of colorectal cancer at earlier ages. It's still in discussion, which this age may be pushed forward in the future. But at this point in time, I think once 50 years old and above, it is recommended to at least get a colonoscopy screen done. Yeah.
How accurate is CA? Will it really show if a patient has cancer? So why do we need to do CA on a regular basis? I think Dr. Isaac has covered this very extensively in his lecture. CA is is a blood test that sometimes our general practitioners will include in their health screening package, but as per guidelines, it's actually not recommended for colorectal cancer screening. In fact, it is only raised in about 40% of all colorectal cancers. What this means is that you could have a normal CA and you may have also an underlying early cancer. Also, it is also raised in conditions that are not associated with colorectal cancer, meaning that there are other conditions associated with raised CA. For example, pancreatic cancer, liver cancer, thyroid cancer may also have raised CA. And also non-cancerous conditions, for example, kidney failure, liver failure, or even having a lifestyle of smoking can also have raised CA incidentally. So I would say that using CEA as a form of colorectal cancer screening is not accurate. However, it is used in a situation when if we have detected cancer and we want to survey and look for recurrence of the cancer. As I mentioned earlier, amongst all colorectal cancers, about 40% are known to be secretors of CEA. And therefore, if you are shown to have a raised CEA on diagnosis of colorectal cancer and you are treated for colorectal cancer, we want to look and identify any recurrences, early recurrences. And how we do that after surgery, we will repeat the CEA every 3 to 6 months within the first 1 to 2 years after surgery. And this gives us an idea whether if it is raised, then we would like to do a repeat scan to look for early recurrence. Or if it's not raised, then we have the reassurance we can give to the patient that there's no recurrence and he can continue on regular surveillance. Thank you.
I have polyps found in the past 2 colonoscopy tests, although non-cancerous, they were removed. How frequent should I have my colonoscopy test moving forward? Now, the frequency of colonoscopy depends on a few things. Number one, your risk. Do you have previous cancer? Do you have previous polyps? And in this case, you have previous polyps, but how many, how big are they? And are they removed completely or not? So if you have 1 polyp, in general, risk is quite low. If you have more than 1, you have more than 3, the risk is higher. You will need to do the test a bit more frequently, maybe 2 to 3 yearly, especially if these polyps are the precancerous type, right? Like you mentioned, adenomatous polyps. So sometimes we even do every year if there are many, many polyps and the polyps are quite big. So the answer to the question is individualized to the patient, depending on the type of polyps, number of polyps in the colon.
Okay, so the question for this one is, no polyp was found during colonoscopy in a 74-year-old man 1 year ago. No history of colorectal cancer, but now has constipation once or twice a week. Does he have to go for colonoscopy again? In this particular instance, I think that depending on what was found during the colonoscopy a year ago, looking at it, the preparation was clear, it was done adequately with a proper visualization. I think the threshold to actually do another repeat colonoscopy is very low. We don't think that anything will go within the 1 year period if it was actually adequately visualized. So I don't think he requires it at this point in time. Following which subsequently, whether or not to continue doing screening in the elderly male, I think that is a discussion that is warranted in a clinic to see whether or not to weigh the pros and cons of whether a colonoscopy, subsequent screening colonoscopy should still be required, especially in elderly patients.
Do prevalence of piles lead to polyps? We know piles and polyps are all very different conditions. Piles or hemorrhoids are just what we call blood vessel cushions around the anus, and they help to actually with ensuring a smooth passage of the stools, and that in certain situations when you have prolonged straining, prolonged constipation, these cushions or blood vessels get increasingly enlarged and engorged, and sometimes over time they cause symptoms such as prolapse. That means it comes out, you feel a lung coming out when you pass motion, or it bleeds when you strain. Now, this is very different from polyp, as what is alluded earlier by, or mentioned earlier by Dr. Isaac, as well as Dr. Aaron, that polyps are precancerous lesions. They are abnormal growths of within the colon or the rectum, and they have different types, of which different types may have different risks of becoming cancer over time. So therefore, and for polyps, they can become cancerous, and therefore we advise to go for early colorectal cancer screening via colonoscopy, so that if it is detected and removed early, you reduce your risk of having colorectal cancer in future. Thank you.
What are the most likely causes of blood in the stool? Fresh blood, what procedure should be done in such cases? The most common causes of blood in the stool that you can see would be piles, right? Anal fissure, and in some cases, colonic growths, tumors, or polyps. So if you do see fresh blood in the stool, it's important to first see a GP or polyclinic doctor and you may get referred to see a specialist. That's what you should do. Thank you.
Okay, so this question is one patient has actually been recently detected to have a sigmoid thickening. I think this was seen on either normal CT scan or CT colonal. Is it a cause to worry? Okay, so I guess this depends on where the sigmoid thickening was found. It was found actually on what modality was used, whether it was a CT colonography or just a plain CT scan. As we previously mentioned, when we go for CT colonography, usually we actually have normal bowel prep. We actually have to clear all the feces out before doing a CT colonography. Sometimes on these CT scans, some thickening may just be due to actually remnant stools in that region. Other possibilities for this thickening might be just due to inflammation from the colon itself. So it's very hard to answer this question just based on one individual scan. If you have just gone for a colonoscopy, I think that would definitely that would help to provide more information on actually whether or not what's the cause of this thickening. So I think probably take it one step at a time, go for the scope first, see what it finds and says, and then subsequently, once more information is available, we can properly ascertain what this might be. Yeah, I hope this answers your question.
How do we know that a colonoscopy have removed all polyps? Small ones may be overlooked. What's the chances that a polyp reoccurs in the same place? Now, it really, like what is mentioned earlier by Dr. Aaron Seah on preparation for the scope, is actually very crucial. Now, if your bowel preparation is very poor, for example, if there's solid, liquid, brown stool throughout the colon, then it's very difficult for even endoscopists to do a good colonoscopy. If it's a good bowel preparation, then of course you have helped endoscopists to visualize every fold. However, and usually we will detect all the polyps that are seen. However, of course, there are some of those that may be behind the fold that may not seen at times. But usually what will happen is that that's why we advise the scopes to be repeated within the 5 to 10 years, so that in the event that we have missed one, it is seen again second when we do the colonoscope or repeat the colonoscope again. Now, usually when a polyp recurs at the same place, usually depends on a few factors. Now, for example, if what was the initial histology of the polyp removed? Now, the polyps are usually adenomatous, but we usually grade them of low grade to high grade dysplasia. Grading affects the risk of recurrence, and also that's the first factor. Another factor is whether it was removed entirely. Now, usually we will try to snare the polyp, like what Dr. Isaac has shown in his videos and presentation, and this usually removes the polyp entirely and prevents and lowers the risk of it recurring at the same place. In those polyps that are very large, like 2 to 3 centimeters, and they are removed piecemeal or sometimes after snaring, they have a risk of recurring again in the same place. And in such situations, because of the size of the polyp, we therefore advocate to repeat the scope earlier, for example, within 1 to 2 years, to look for early recurrence. Thank you.
Can colon cancer be avoided through lifestyle? I've answered this earlier. Lifestyle is only one of the different factors that can increase the risk of colon cancer. But lifestyle is a modifiable factor, right? Your age, your environment, your race, and genetics can't really be modified. So the answer is it can be, your risk can be decreased, but it can't be avoided, right? It can't be completely eliminated in a way. So a healthy lifestyle, balanced diet, avoid smoking, avoid too much, unhealthy alcohol. These things has been shown to decrease the risk of colon cancer, but does not prevent it completely. Thank you.
So the question is where and how to go collect the FIT test kit without a letter. So I think actually what happens is the Singapore Cancer Society actually has a very, very good support system regarding this. I think they actually have online, there's an online form in which they request us for NRIC, date of birth, email, and subsequently they will send the FIT kits through the mail towards your own home address. I think this can actually be found on the Singapore Cancer Society website. We'll try to find the link, then maybe we'll post it in the chat for you all, but give us some time to try to see if we can sort one out.
The link will get posted. The SCS link will get posted again later. So just scan the QR code and you can send it to you. The other thing is that it's actually widely available in most places. You can even walk into SGH or NCCS and pick it up from most of the counters, and you can do that at Watson's or Guardian as well. So it's very accessible.
Thank you, bro.
Okay, considering a degree of radiation, CT colonography, colonoscopy, fluoroscopy, barium, I have a good bowel clearance habit, though I feel a small lump below abdominal region, nearer to the pelvis. Kindly advise. I'm not very sure what you're trying to ask. Are you trying to ask what is the right investigation for you? Firstly, I would say that this forum does not replace a formal consult. If you are concerned over any form of mass or growth within the abdomen, I would suggest you go and seek a formal doctor consult, because you need to palpate the lump to assess what is the right investigation for you. But of course, if you feel a mass in your abdomen, first seek early medical attention. You probably need to be worked up with a CT scan. But like I said, this forum does not replace this. You probably need some form of radiological imaging first, and if there is clear, we will definitely advise for some form of colonoscopy. Thank you.
Is the colonoscopy procedure subsidized? Yes, it is subsidized. And it can be Medisave claimable too. Medisave, MediShield, and insurance claimable, even though it's a day procedure. But insurance can be used for this procedure. So yes, it is. Thank you.
So the question is, are there any other alternatives if can't perform colonoscopy for elderly as unable to take the required water to do colonoscopy? So I think there are a lot of avenues to this question. First thing first is for every colonoscopy, the preparation of the bowel prep required, there are different regimes available. I think the most common one we use is a PEG, which is 2 liters of water, flushing that down. Of course, I think that anecdotally actually provides us the best bowel preparation and clarity. But there are other alternatives also, which is a smaller volume, such as the PicoPrep. Such as a PicoPrep, with smaller volume, which actually helps to see. But there are certain contraindications to allowing that to use its usage. So if after all that it's still not an alternative to go for colonoscopy, CT colonography is also another option. But then again, that takes a smaller volume, but it is an amenable option to see, especially in elderly patients. Hope that answers your question.
Great. Thank you very much to our panelists, Aaron, Isaac, and Dr. Lionel Chen. Ladies and gentlemen, we've come to the close of today's webinar. Thank you very much for joining us this morning and on colorectal cancer awareness. We hope you'll take the opportunity to consider early screening and keep yourselves healthy. Thanks again.